The majority of the patients that we will use PRT tends to be second line and beyond. And when we put in context all the treatments that we have, I think especially for the mid-gut tumors, PRT is definitely the winner when it comes to second line treatments. It's an exciting time to be a doctor taking care of neuroendocrine tumors.
Ken, if the disease is progressing on somatostatin analogs, Rohit brought up a few treatment options: everolimus, cabozantinib, and PRRT. For PRRT, we often get nuclear medicine or radiation oncologist on board. In a patient that has dotatate positive disease, and you're seeing this patient to consider PRRT, what do we have to support this practice? And in real life, what does that conversation look like for that patient in front of you?
There's a lot of very, very good data to underline that somatostatin 2 receptor imaging with PET is better than anything else. Nevertheless, I think it's very important that we actually perform this imaging technology always in addition with the contrast enhanced CT. We need to know that the lesions which are disease dominating are somatostatin 2 receptor positive. And for this, we need the additional information from the CT plus the PET information. Right. And in these patients, actually, we really discuss, depending on the previous treatment, if the patients are candidates for PRRT. And we actually usually perform this in MDT, where we bring all together the different level of information, and also something which we also have to discuss, how quickly is the disease evolving, because PRRT is not a therapy which you treat one time and you will see a response within 1 or 2 days. It's a treatment which needs time to be efficient.
We do have data from the NETTER-2 that shows that in patients with more aggressive disease within the well-differentiated GAP-NET ward, there is a role for first-line treatment with PRRT. Having said that, the majority of the patients that we will use PRRT tends to be second line and beyond. And when we put in context all the treatments that we have, I think especially for the mid-gut tumors, PRRT is definitely the winner when it comes to second line treatments. And just this year, in March, we had a presentation during the European Neuroendocrine Society meeting that showed via the COMPETE study that lutetium-177 DOTATOC was superior to everolimus, and they use the active comparison of everolimus. So, and that really, to me, consolidated the role of PRRT, particularly in second line. I think the decision of first line is a little bit more complex, even though the data was positive. Do you miss too much in still using a somatostatin analog? We have the data in progression-free survival benefit, but we don't have overall survival. So I think definitely for the higher grade tumors is a little bit more of a discussion. And in terms of well-differentiated G3 tumors, because we don't have this population of patients, we potentially see the benefit as well. It's just a question as how fast the tumor is progressing, and do we have to start with something else sooner, because sometimes depending where you are, it might take time to set up PRRT.
Ken, keeping that patient in mind that's getting PRRT under your care, what are some of the side effects that we see with this modality? Any clinical pearls to manage this?
Then the most important toxicity depends on the angle. If you talk to the patient, actually for them, for us, the most important is that they really do not like nausea, which is actually not associated directly to the treatment itself, but rather to the kidney protection, these amino acids which are infused. When you talk to the regulators, they actually worry the most about the kidney dose and the potential kidney toxicity. And the third one is then the clinical angle, and the clinical angle is something in the long term we are the most concerned about, is actually the bone marrow function.
I think it's an exciting time to be a doctor taking care of neuroendocrine tumors. We have so many new treatments coming, and I think PRRT is here to stay. And then I think very soon we will be talking even about retreatment with PRRT, because we now have trials that are even assessing the goal of re-challenging patients with PRRT if they had the initial response to that. So very exciting times for the treatment of neuroendocrine tumors.
There are multiple different molecules that will soon be available to us, and this field is moving fast. Now we also have positive data from COMPETE study for first and second line PRRT in well-differentiated grade 1 or grade 2 tumors, but selecting the right patient and pairing them with the right treatment option is the key.
Yes, Rahul. Multi-D is critical, and referring and partnering up with tertiary or quaternary centers early for us in the community is extremely important. As we heard, data for lutetium dotatalk, when compared to everolimus, has now consolidated the role of PRRT as a second-line therapy for neuroendocrine tumor, but it is also showing promising results in first line as well.